Welcome! The following presentation from Answers in CME is part of an educational activity titled Biomarker-Driven Insights in Transthyretin Amyloid Cardiomyopathy, Interpreting the Impact of the Latest Evidence. To access the full program and supporting materials and to claim your certificate, please visit the activity URL in the episode description. This activity is supported by an educational grant from Bayer AG.
My name is Mariana Fontana. I am a professor of cardiology at UCL in London, and I work as a cardiologist at the National Amyloidosis Center. For this session, we'll be discussing the TTR pathway and the mechanisms of action for disease-modifying therapy in ATTR-CM. Transthyretin, or TTR, is a soluble tetrametic protein produced primarily by the liver and circulates in the blood and CSF. It transports thyroxine and retinol and is involved in multiple physiological functions, including neuroprotection, pregnancy, and glucose homeostasis. What happens in patients with ATTR amyloidosis is that the protein destabilizes and then misfolds and deposits in multiple organ and tissue, and is the deposition of the protein itself that causes disruption in tissue architecture and ultimately organ dysfunction. Misfolding occurs in elderly humans with wild-type ATTR amyloidosis, so the gene is in its wild-type form. But when there is a variant in the ATTR gene, then we call it ATTR variant. And the disease can present with a predominant cardiomyopathic phenotype, very similar to the wild-type form, or with a predominant neuropathic phenotype, where the patients have peripheral neuropathy and autonomic dysfunction. But now we know that the most common phenotype in patients with variant disease is actually the mixed phenotype, where neuropathy and cardiomyopathy are present in the same patient. We have two classes of drugs within the disease-modifying treatment drugs that target the new amyloid production and deposition. We have stabilizers, and this is the first class of drug that was approved. So the protein is reduced, but then is stabilized in the normal conformation. And within this class, we've got the tafamidis, which targets the T4 binding site within the protein. And then we've got acoramidis, which stabilizes hydrogen bonds at T4 binding site. And this stabilization is done by mimicking a stabilizing variant. A new class of drugs have been approved, which is the TTR silencers. Within this class, we've got only one compound for ATTR cardiomyopathy, vutrisiran. And what this class of drugs does is that reduces the production of the TTR protein from the liver. The key differences also lie in the route of administration. Acoramidis is oral twice a day, tafamidis is oral once a day, and vutrisiran is an injection by clinician, patient, or caregiver, which is given once every 3 months. In the next session, we'll be discussing biomarkers used to assess disease and guide therapy in ATTR cardiomyopathy. In this session, we'll discuss biomarkers and disease features used in clinical practice to guide disease-modifying therapy. So how do we assess treatment response? We can assess treatment response using clinical markers, and within this group, we've got heart failure related hospitalization and worsening heart failure in the outpatient settings, which is measured as outpatient diuretic intensification. Within the clinical biomarkers, we have NT-proBNP with an increase of 700 picogram per milliliter, associated also with a relative increase of 30%. And we also have eGFR with a relative decrease of more than 20%. But what about functional markers? So markers that really matters for patients. So we know that we can assess very easily functional capacity with a 6-minute walking test, and a decrease of more than 35 meters is again a strong prognostic marker. So quality of life really matters, and we now know that a change of 5 points in KCCQ or a change in NYHA functional class again is strongly prognostic. Disease progression can be considered if at least 2 parameters meet the defined threshold, but each of them has got an incremental prognostic value. So having 1, 2, 3, 4 of these parameters stratifies the risk. And usually we measure these parameters at least every 12 months, so 6 months in more advanced patients. But clinical practice is really evolving, and while these markers are useful, they do not directly measure the specific pathway which is targeted with the treatment. And more we are measuring the TTR level as a potential marker of treatment response in patients treated with stabilizers and silencers. So serum TTR levels below 15 or 18 milligram per deciliter had been associated with worse outcome, including heart failure, hospitalization, mortality rate, and decrease in cardiac function. And this is before any initiation of disease-modifying treatment. So at baseline, the lower the level, the worse the outcome. And this one is probably related to the instability of the protein. The more unstable the protein, the lower the level. But what's changing now is that we are trying to use the TTR levels to track the response to treatment. So not only as a prognostic marker at baseline, but the change in TTR levels seems to give extremely important prognostic information in patients who start treatment. So gene silencers, they've reduced the TTR level from baseline because they reduce the production of the protein. Instead, what we see with stabilizers is that by stabilizing the protein in the normal conformation, they increase the TTR levels. And very robust data published from the ATTR-CM study report that the serum TTR levels increase with acoramidis at day 28 has got an important role in stratifying patient prognosis, i.e. an early increase in serum TTR levels at day 28 is associated with better prognosis. And serum TTR levels of more than equal than 20 milligram per deciliter was correlated with improved survival over 30 months. In the next session, we'll discuss the clinical evidence supporting the use of TTR stabilizers and silencers in ATTR cardiomyopathy. In this session, we will discuss the efficacy data for approved disease-modifying therapies in ATTR cardiomyopathy. In terms of the ATTR-CM trial, which was the pivotal trial, phase 3, randomized placebo-controlled trial assessing the efficacy and safety of acoramidis in patients with ATTR cardiomyopathy, which recruited 632 patients, this was a highly positive trial. It met the primary endpoint, which was a composite hierarchical endpoint, including death from any cause, cardiovascular hospitalization, NT-proBNP, and 6-minute walking test. And what do the trial results mean for patients? As we discussed, cardiovascular hospitalization is probably one of the most significant clinical events that can happen in the life of our patients because cardiovascular hospitalization are strongly associated with worse prognosis. And cardiovascular hospitalization during the 30 months of the trial was reduced by half. But what about other drugs? The ATTR trial was the first trial that was published with a disease-modifying treatment in the field of ATTR cardiomyopathy. And again, a randomized phase 3 placebo-controlled trial, but this time testing tafamidis, again, another stabilizers versus placebo in 441 patients. It was a highly positive trial, met the primary endpoint, death from any cause and cardiovascular hospitalization at 30 months, and was also positive across all the key secondary endpoints. Patient population is very different from later trial because back then we were diagnosing the disease much later, and so the patient population overall was much more advanced compared to the patient population that we see today in clinic. So we need to be extremely careful in doing head-to-head comparison because we're talking about different population, different trial design. So we need really to assess the trials in isolation. A third trial, the most recent one, was the HELIOS-B trial, again a phase 3 randomized placebo-controlled trial, which assessed the efficacy and safety of vutrisiran TTR gene silencers in patients with ATTR cardiomyopathy. 655 patients, again, another highly positive trial, met the primary endpoint of death, recurrent CV events over 36 months, and was also positive across all the secondary endpoint. Again, we need to pay attention to populations, especially in this trial. There was a proportion of patients on background disease-modifying therapy, so tafamidis, and there was also a difference in supportive heart failure medication. In the next session, we'll discuss the safety profiles of these therapies. In this session, we'll discuss the safety profiles of approved disease-modifying therapies for ATTR cardiomyopathy. So going back to the trial that we discussed before, and starting from the first one, the ATTR-CM trial, which tested the efficacy and safety of acoramidis, there was a general good safety profile with no safety concerns. These translate in clinical practice in no specific safety monitoring and no specific medications that needs to be taken together with acoramidis. In terms of the ATTR trial, so testing the efficacy and safety of the tafamidis in patients with ATTR cardiomyopathy, there was a general tolerability of tafamidis, and there were no specific recommendations in terms of safety monitoring, and also no specific recommendation in terms of medications that need to be taken in addition with this drug. In terms of the most common adverse events in my clinical practice, some patients can experience bloating and diarrhea, but this only lasts for the first few weeks and then disappears. The last trial, the HELIOS-B trial, so different mechanism of action. Here, instead of stabilizing the protein in the normal conformation, we are reducing the production of the protein from the liver. And in the HELIOS-A study, vutrisiran decreased the serum vitamin A levels by 70%, with consistent effects also seen in the HELIOS-B trial. In terms of safety recommendation, we need to make sure that patients are treated with vitamin A supplements, so 2,500 to 3,000 units a day, in conjunction with vutrisiran. As clinicians, we're extremely lucky in patients with ATTR cardiomyopathy. Disease-modifying treatment do not require any specific safety monitoring. In the next session, we'll discuss the optimal timing of disease-modifying therapy. In this session, we'll discuss the impact of early therapeutic intervention in ATTR cardiomyopathy with disease-modifying therapy and best practices to enhance timely treatment initiation. So in the subgroup analysis, when we looked at high or low NT-proBNP, high or low eGFR, or NYHA class, the patients that were earlier on in the disease, they did significantly better with treatment. So the most important thing that we can do as clinicians is to start treatment as soon as possible, thanks to a very timely diagnosis. But the treatment targeting is really evolving. Until now, we thought about delaying disease progression, but early evidence from the ATTR-CM trial is pointing towards disease reversal in a proportion of the patients, with improvement in NT-proBNP, improvement in the 6-minute walking test, and actual amyloid regression as measured by the CMR with ECV mapping. So early diagnosis remains the most important thing that we can do for our patients. Remember, ATTR cardiomyopathy is a common cause of heart failure in the elderly, so suspicion and awareness of this disease remains the most important point. And what can help are ECG findings, echo findings, cardiac MRI in patients who have cardiac MRI, and also persistent low elevation of troponin, as well as elevated BNP or NT-proBNP. So when we think about when to initiate treatment, the answer is extremely simple. As soon as possible. As soon as a diagnosis of ATTR cardiomyopathy is confirmed, then we should start treatment. And as clinicians, we're extremely lucky because in the field of ATTR cardiomyopathy, we have 3 different drugs that have proven to be extremely effective in changing our patient prognosis. So how do we decide between the treatment? A discussion with the patients is always the key, because patients might have preferences on oral administration versus subcutaneous injection or daily administration as compared to 3-monthly administration. And how do we assess treatment response and disease progression? We discussed that there are clinical and also functional markers, but also biomarkers such as serum TTR levels and NT-proBNP can be used to guide treatment decision and monitor treatment response with this disease-modifying therapy. How frequently would we measure these biomarkers? Every 12 months in most patients or every 6 months in more advanced patients. And then, of course, a treatment adjustment should be considered in patients who continue to progress. In summary, ATTR cardiomyopathy can be treated with approved TTR stabilizers, acoramidis and tafamidis, or the approved TTR silencer vutrisiran. All 3 therapies have demonstrated clinical benefit in terms of all-cause mortality, cardiovascular hospitalization, functional tests, and quality of life. Early initiation of these therapies is critical to preserve cardiac function and reduce the risk of hospitalization or death. Biomarkers such as serum TTR and NT-proBNP can be used to guide treatment decision and monitor treatment response with these disease-modifying therapies. Thank you very much for the attention.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.